Hi, my name is Sherry. I'm going to introduce Dr. Millett, who's the director of the Hoag Epilepsy Center here in Orange County in Newport Beach. He's been the director since 2014, and he's also worked with Rancho Los Amigos and USC. Today he's going to be giving a lecture on understanding your EEG. So in lieu of time, and I will introduce Dr. Millett.
Thanks, Sherry. Small crowd to begin, but hopefully we'll pick up a little bit, and it'll give us an opportunity to answer individual questions, which is usually kind of the most interesting and fun part of this talk, because people have all kinds of funny EEG questions. So this is, it's funny, I tried to cram an incredibly technical talk that I just came from that was scheduled for 25 minutes into 15 minutes because the speaker before me went 10 minutes over. And then I think that I've been given more time to talk about EEG this year than I have any other year in the history of the Expo. So I've been giving this talk as part of the Expo since the Expo began 7-8 years ago, when we were just all in little bar stools in the corner of the room here. EEG is a mystery to many people, and we refer to them as squiggles and scratch marks and spikes and waves and polyspikes and GPFA and posts and all kinds of acronyms within the field. So this talk is really meant to sort of demystify, in some degree, EEG, and I'm going to make it a little bit personal because I came to the field of epilepsy in a bit of an unusual route. I did a combined MD PhD program, and my PhD was in history of science, and so I actually got a chance to write the history of EEG before I stepped into doing it as a practitioner, which was pretty cool. So I got a chance to go to Boston Children's Hospital and take a look at those old scrolls that you see Bill Lennox and the Gibbses looking at in the middle of the screen. And I actually went to Germany and to look through Berger's archives and his diaries that led him to discovery of the EEG back in the late 1920s. And I spent some time up in Montreal, where you see one of the first epilepsy surgeries based on EEG in the late 1940s. So the EEG is a field that's been near and dear to my heart for the last 25-30 years. So I'm going to talk a little bit about it today. Of course, today EEG looks quite different from the way it was practiced in years gone by, the 20th century, or at least the mid-20th century. One of the most important landmarks in the history of EEG was in 1958 when Herb Jasper, who was then at the Montreal Neurological Institute, published what became quickly known as the 10-20 system. So the 10-20 system is a system of measurement that allows everybody who's performing EEG around the world to know exactly where to place electrodes on any patient's scalp, so that we can know that we're all talking about the same thing. And so when there are anterior temporal discharges that are reported from a patient in Orange County or in London or in Japan, we know that everybody's using the same system for measurement application of the EEG electrodes, and that information is basically transferable across technicians, across programs, across countries, and it basically refers to the percentage of the distance between different electrodes over the head. And each one of those electrodes has a very specific name, and we'll get into kind of what those look like on the EEG printout. There are certainly other types of electrodes that have been developed over time for other specialized purposes. So you can see the same 1020 system of recording in a net. This is oftentimes used in high volume hospital settings because it reduces the time that it requires to apply individual electrodes. But here you see an infant with the individual electrodes placed on their head. This is one image of a newer system that has a reduced number of electrodes for rapid application of an EEG, so that this is called the Cerebell system. There are a few of these around that don't require technicians to apply in emergency situations, in the emergency room, when patients come in and we really need to know, are they having seizures in front of us, whether or not we can see them, or if we've given drugs to stop seizures, have they really stopped seizing, or have the seizures gone on to be electrical only? So this is a pretty slick system to apply, not without its limitations, but we can get real data in within about 5 minutes, regardless of where we are in the area, as long as we have an internet connection. And then finally, in the lower right system, I mean, this is also a form of EEG, but it's a very different form of EEG. These are individual depth electrodes. These are thin wires with multiple contacts, typically 5, 8, or 10 contacts along the shaft of the electrode that have been implanted in this patient's right temporal lobe to try to better understand where the seizures are coming from and how are they spreading in order to tailor treatment, oftentimes surgical treatment. That might be a laser ablation, that might be a lobectomy, that might be implantation of a neurostimulation device. But this is also falls under the heading of EEG. So I'm going to focus for the next 20-25 minutes on scalp EEG, just routine EEG, and then I'm happy to answer any questions. And by the way, if anybody has any questions along the way, raise your hand if it's a pressing question related to what's on the screen or something flashing through your head, if you don't think you're going to remember it at the end, okay? So that's where the electrodes go. And then these are typically what we call bandwidths or wavelengths in the EEG. So we talk about different types of rhythms. These are endogenous rhythmic oscillators of brain activity. They are characterized by the frequency range. The fastest is beta. Beta activity is above 12 hertz, typically defined as 13 to 30 hertz. Oftentimes seen over the frontal lobes, but can be seen over other areas of the brain if a patient is very still and there's not a lot of electrical noise around. What unfortunately happens is that when muscles are activated, the temporalis muscle, frontalis muscle, or if it's an electrically noisy environment, the very high frequency activity sort of drowns out whatever beta is coming from the brain. But beta activity, when it's recorded from the brain, oftentimes is seen over the frontal lobes during drowsiness, transition from awake state to sleep. We often will see beta over the vertex. Alpha, the next in descending order of the frequency bands, that's the next one, is typically 8 to 13 hertz. Alpha is probably the most famous bandwidth that we talk about or know about. So the alpha rhythm, or the posterior dominant rhythm, is a normal background activity in most awake or drowsy folks. It's typically recorded over the occipital region. It can have a narrow field, really just over the occipital, or we can actually record it from a broader field over the occipital, parietal, and posterior temporal. It's just that in some patients it's narrow and in some patients it's broad. It just has to do with how those rhythm generators are hooked up to the deeper nuclei. But as you can see, it's typically this sinusoidal pattern called the alpha rhythm or the posterior dominant rhythm in the 8 to 13 hertz range. Most commonly seen is about 9 hertz. And this is just normal background activity. When we see a posterior dominant rhythm in that range, we know that there's no significant cranial injury, whether that's acquired, like a stroke, or congenital. We know that there's the circuitry to create the normal background activity has been preserved. Theta activity then is a little bit slower in the 4 to 8 hertz range, typically seen in in children, normal children awake and asleep up until the age of about 10. You can see a fair bit of theta in the background intermixed with this alpha above, or in adults who are transitioning to sleep. We oftentimes will see theta activity in the drowsy state. Delta is, again, in normal folks, typically only seen in slow wave sleep. When we see delta activity in the awake state, it usually indicates some degree of pathology. If we see delta activity over a particular area of the brain, that usually indicates that there's been some injury to that area. There might have been a stroke, there might be a tumor, there might be some other problem, but it's usually indicative of some kind of a structural injury. If we see delta over the whole brain, it usually means that there's some global brain problem, whether that's a genetic problem, a metabolic problem, whether there was this is a patient that perhaps had a cardiac arrest and the brain didn't see enough oxygen for a period of time and has suffered some permanent brain injury. Delta in adults, awake adults, is always bad news in terms of there's something wrong here. And then finally, on the lowest panel here, what you see is a pretty typical or classic example of 3 hertz spike in waves. So this is a pattern that you might see in a patient having an absence seizure or generalized seizure, in which we see repetitive narrow spikes, less than 70 milliseconds, and then the aftergoing slow wave. And 3 hertz is the most common frequency that we see these in what we used to call the idiopathic generalized epilepsies, or absence or petit mal seizures. So now these are just individual channels. An EEG obviously isn't an individual channel. It's a whole page of squiggles that are sometimes hard to interpret. And so what I've tried to do here is to basically give you an example of the way in which those electrodes are oftentimes hooked up and what they represent. So this just happens to be an arrangement of EEG channels that I like to use. It's sort of my default reading montage. Montage is the term. It's a French term, but it's a term that's used to describe the arrangement of EEG electrodes on the page. And this is what we refer to as a bipolar montage, bipolar as opposed to referential montage. I'll just touch on the difference. So bipolar montages are arrangements of EEG electrodes in which the electrical activity at 2 different areas over the scalp are connected to one another. And what we're looking at is the difference between point A and point B. Whereas in a referential montage, as the name might imply, we pick one reference point or one reference value, and we look at all of the different areas over the head of the surface of the head as they pertain or as they relate to a single reference point. Sometimes that reference point is physical, like we might decide we're gonna look at all of these electrodes over the surface of the brain and compare them to what's going on here at the vertex at CZ. And other times that reference might be a mathematical reference. So we take all of the input from all the different electrodes, and then we create a mathematical average, and then we subtract each point of the brain minus that average, and that tells us what's this unique activity at that particular point. So these are just different ways of highlighting the electrical activity of the brain. When I'm sitting down with a patient and I'm trying to go through this bipolar montage, what I explain to them is this top group of 4 squiggles essentially marches out the electrical activity of the left temporal lobe, starting here at FP1. FP stands for frontal polar. The higher the number, the further from the midline. So FP1, very close to the midline at the frontal pole, minus F7. F7 is labeled F as frontal, although it lies right over the temporal tip. So this first line here, this first channel, basically looks at the electrical activity of this part of the brain. And then the channel below connects F7 to T3, mid-temporal. So that's basically marching backwards. And then we go T3 to T5 is here, and T5 to O1 is here. So these top 4 channels, or these top 4 squiggles, march out the electrical activity over the left temporal lobe, starting at the pole and going all the way back to the occipital lobe. As you can see from the diagram, the next set of 4 squiggles or channels does the same thing but on the right side. So we have FP2 to F8, F8 to T4, T4 to T6, T6 to O2. So if we're wanting to compare, hey, what's going on the left temporal lobe compared to the right temporal lobe, we have this group, this chain of 4 channels that are reflecting the electrical activity over the left temporal lobe. We have this group of 4 channels reflecting the electrical activity over the right temporal lobe. And then it gets fancy. This middle chain starts on the left and goes over the head, sort of like an 8-year-old's beret, right? Or I have an 8-year-old girl. She has these little things to hold her hair in place. She loves them. So this basically starts here. T3 looks at the temporal, and then the central on the left, and then the central on the right, and then the temporal on the right. And these bottom two chains, each containing, again, 4 channels, individual squiggles of electrical activity, are very similar to what we saw above over the temporal lobes. They're just higher. They look at parasagittal, or just to the left and right of midline. So they have the same beginning and end point as the temporal chains. They just come higher. So they look at more frontal lobe, parietal lobe function, and occipital lobe function as they start at FP1, then to F3, F3 to C3, C3 to P3, P3 to O1. The odd numbers are the left side of the scalp, even numbers the right side of the scalp. F stands for frontal, O is occipital, P is parietal, T is temporal. Z, the subscript Z, refers to the midline. So anything that you see with a Z on it, so CZ is the vertex up here, and you can create a lot of different montages. Everybody has their own preferred reading montage. This happens to be mine. On the right, you can see this is a referential montage. So we've picked many of these same points of interest over the head, and we've just subtracted the average of all the points in the head, the electrical activity everywhere, from those individual points, and they have different advantages and disadvantages. So when an electrical impulse is very focal, and in this illustration coming over from the right temporal lobe, the bipolar montage, or way of arranging the EEG electrodes, turns out to be the most advantageous because it actually pinpoints based on the polarity of the individual channels. It actually pinpoints the more precise location of that what we call the irritative zone, or potentially the seizure onset zone. Whereas if you take the same discharge here and look at it in a referential montage, you might sort of miss that, well, hey, it's coming from exactly from this area, from the temporal lobe on the right, because if we pick a distant point, this area is, this abnormal electrical activity has a local field, and we're going to pick up not only the epicenter, but we're not only going to pick up, you know, the 7.2, but we're going to pick up the 6.5 and the 3.4, all the different, you know, seismic, just using the seismic metaphor. And so we're going to see contamination in a referential montage. So referential montages have their use, but in most recordings, the bipolar tells us really where is the precise location of that irritative zone in the brain. Okay, so that's all I'm kind of going to go over with regards to the technical display of EEG and the way of understanding them and laying them out on the page. I'm going to touch a little bit about the different types of EEG, because you may have heard these terms: routine, extended, ambulatory, inpatient, EMU, whatnot. So routine EEGs can be done either inpatient or outpatient. That's typically a 20-minute study. These terms typically refer to the duration of the study itself. So a routine EEG is typically a 20-minute study, can be done, again, at the bedside in a hospital, can be done in the outpatient or in the outpatient laboratory. An extended EEG is anything above 20 minutes, but typically is done either at 45 minutes or an hour in duration. There are some pediatric centers or labs that will do a 2-hour or a 4-hour outpatient EEG. I personally think it's a waste of time, because if you're going to record for that long a time, you just hook up a patient, send them home, and get 24 hours. I think anything beyond an hour is doesn't make a lot of sense to take up the lab, the EEG lab for that period of time. But I will routinely, not to confuse the issue, I will most often order an extended 45-minute EEG. I don't consider a 20-minute EEG actually sufficient for diagnosis, unless we've captured something on it. And the reason is that the most important state to capture in an EEG is sleep. Sleep is the most provocative state that brings out abnormal activity. And in 20 minutes, especially if the tech is hooking up and asking questions and fixing electrodes, and maybe doing hyperventilation and maybe doing photostimulation, especially if it's in a kid, a 20-minute EEG is nothing. And I've certainly known many patients who ended up with about a 10-minute or a 12-minute EEG in an emergency room that was negative, and that's just not a useful bit of information at all. The longer period of time that you can record, the better, and any recording has to include sleep. If it doesn't include sleep, it's not really going to provide optimal information. Am I talking too fast? Okay. We move from routine and extended then to long-term, either with or without video. And this can be done either in the inpatient setting, that's typically the epilepsy monitoring unit, and any level 3 or level 4 epilepsy center will have an EMU. That is a dedicated space with hardwired equipment, somebody watching the patient at all times, and continuous video and EEG recording. Typically with an EEG technician, either close by or on standby to adjust electrodes or to fix things up if things go awry. And then we have ambulatory, which is an in-home solution, which works very, very well for relatively shorter periods of time, so 24 hours, 48 hours, and sometimes even up to 72 hours in a compliant patient. We can get very high-quality ambulatory data. I have actually taken a small number, less than 5, I think probably 3 patients through the epilepsy surgery process to surgery without actually ever admitting them to the hospital, because we've got enough data on an ambulatory study, an in-home study, actually to figure out exactly where their seizures are coming from, what they look like, and to plan the surgery. Doesn't happen that often, but the technology and the in terms of the high resolution video and the amplifiers have become high quality enough to actually get the same quality of in the outpatient setting, in the ambulatory setting, as we often obtain in the inpatient setting. And then some patients just don't do well in the hospital. So the ambulatory is very useful for kids and adults who have a lot of trouble with being confined to a bed, confined to a room, a lot of behavioral issues. So sometimes ambulatory is very helpful in those situations as well. We have intracranial EEG as well, and I showed you a picture of a patient who had a handful of electrodes that were implanted in the temporal lobe. We can use that both from a diagnostic standpoint in terms of trying to identify exactly where the seizures are coming from in the brain, and then with one of our implanted devices, in particular the RNS device, we're actually reviewing EEG recorded from the device in our patients that are walking around, living their lives, unfortunately having seizures oftentimes, but we're actually able to review that EEG data from a limited number of channels. We only have 4 channels, so 8 electrodes typically hooked up in pairs of electrodes to make 4 channels, but we use that to guide therapy in some of our implanted devices. We also have some EEG applications that have primarily a research or a very high-end clinical application. So we don't do these things on everybody, but sometimes high-density electrodes, so what's called a 10-10 arrangement, where we're basically double spacing electrodes. Sometimes they do make these caps that have over 100 electrodes that for research purposes help us to better identify exactly where the seizures are coming from when it's a very deep source and difficult to identify. There are some centers that perform something called ESI, or EEG source imaging, or source localization, where, similar to an MEG or magnetoencephalogram, they can use mathematical models to better understand exactly where in the depths of the brain certain signals come from. And finally, we use EEG in conjunction sometimes with fMRI to look at the blood flow in the brain and how that relates to different EEG patterns. I think the rest of the talk just kind of goes through some examples of EEG. I'm probably ahead of time, or certainly on par with time. And so I'm going to just go through a few examples of EEG, and then I'm going to open it up for questions, because usually that's the most important part of this talk. So this is a typical 10-11 seconds of EEG. That's recorded. This is probably either a drowsy adult or maybe an awake child. The first thing that we look at is these posterior channels here, the left posterior and the right posterior. So what's the frequency here? What's the bandwidth? So this is approximately 1, 2, 3, 4, 5, 6 hertz. So this is in the theta range. This would be normal for maybe a 2-year-old, or a drowsy adult. But it would be slow for a normal adult because, as I mentioned, the normal alpha range is between 8 and 13. So this background activity would be possibly slow for an adult. But we also looks like we don't see eye blinking. We don't see a lot of muscle artifact. So yes, sorry.
Are you talking about the down below or up top?
We can't see your cursor.
Oh, sorry.
No, you're good.
Oh, is it a cursor?
You, can you not see the arrow?
No.
So this channel here, this is the left occipital channel. This is the right occipital channel. So the first, whenever I open up an EEG, the first thing that we try to ascertain is whether the background activity is normal or not. And then there's an evolution during development, but any child over the age of 3 should have a posterior dominant rhythm of 8 hertz or more. So as we can count these out, we have 1, 2, 3, 4, 5, 6, maybe 6 and change. But yeah, it's probably 1, 2, 3, 4, 5, 6, about 6.5 hertz. So each one of these solid lines is a second. So we have 6.5 cycles per second, or 6.5 hertz. That's the background activity for this EEG, or this segment of EEG. So in a small child, let's say 2 years old, this might be normal. This is an awake child. It might be normal in a drowsy adult, but if this is an awake, wide awake person, this EEG is slow. We also can see other elements that indicate some slowing because we see some waves here. These are delta waves, so this is probably about 3 hertz here that's intruding into the background activity. This is probably a drowsy patient because they're kind of, you see this slower activity kind of going in and out. It's like more prominent here, but then it speeds up a little bit in the second half of the page. So, but this is a typical 11-second epoch of EEG that we review on a screen. And I would typically review, I read a lot of EEG. I read about 500, 600 studies a year, usually 24, 48, or 72-hour studies. So I would typically look at a 24-hour study in about 11, 12 minutes. So it's kind of, we're going very, very quickly through a lot of EEG. This is an abnormal EEG. So you can see this is the same montage. So we have left temporal, right temporal, the coronal chain here, and then parasagittal over the left, and then finally parasagittal over the right. And what we can see is sort of a slow background like we saw in the previous, but it's now interrupted by these spike wave complexes. So this is where it's really nice to have that bipolar montage because it really points us to exactly where these discharges are coming from. So we can see this what we call a phase reversal. You can see this maximal negativity of the left temporal and the anterior and posterior temporal pointing to one another. That indicates that the region of maximal electronegativity, or the maximal area of abnormal electrical activity, is in the mid-temporal or mid to posterior temporal region on the left, but it also has quite a big field because it involves the central as well. So this is a typical pattern for what we call childhood epilepsy with centrotemporal spikes. It's a very typical arrangement of abnormal discharges, and this is what those discharges look like. They become very frequent in patients as they transition to sleep. So this patient, just a highlighted point that I made a little while ago, this patient in the awake state might have a completely normal EEG. If you looked at an hour of EEG, 4 hours of EEG, you may not see a single spike on this EEG. But this patient goes to sleep, and all of a sudden you've got a run. Every page is going to be chock full of discharges. So the sleep component of the EEG, the importance of that, really can't be overestimated. Uh-oh, what happened? There you go. So this is another example. We see similar discharges, but now we're seeing them not only in one hemisphere, but we're seeing them in both hemispheres. This is a patient that has left temporal discharges here, maximal generally over the anterior to mid-temporal, and then right temporal discharges here. Remember I told you this is the left temporal, this is the right temporal, and so we're seeing discharges flip-flopping between the two different sides of the brain. So this is a patient that has bitemporal or bilateral temporal disease, at least an active irritative zone in each of the temporal lobes. We don't know if seizures come from both of them, but they're not normal for sure. So this gets to be kind of a much busier slide for a couple of reasons. So number one, this is stage 2 or sleep or N2 sleep. I can tell because there's some faster activity here over the vertex, which we refer to as sleep spindles. This is a stage in which we oftentimes will see very high frequency of discharges in patients that have established epilepsy, in particular generalized epilepsy or epilepsy syndromes, Dravet, any of the genetic syndromes can have very, very high frequency of generalized discharges in sleep. So here we can see, I mean, hardly a second goes by without either generalized discharge or focal discharges. You can pick individual focal discharges here over the left central, and then we have these very high amplitude generalized discharge. So this is a very complicated EEG pattern. These are where, there's a paragraph that describes all the abnormalities at the bottom of the page. Now when discharges occur this frequently, whether it's awake or just in sleep, they can sometimes have neurocognitive effects or neurobehavioral effects on the child. The technical definition for the very high frequency can be ESES, electrical status epilepticus of sleep, or continuous spike wave activity, or slow wave sleep. Traditionally, that required 80% of the slow wave sleep time to be occupied by these discharges, but even if it doesn't meet that threshold, certainly 60 or 70% of your sleep is chock full of these discharges. That's concern for the possibility that there's so much abnormal epileptic activity that it's really interfering with brain function, with restorative sleep. Let's see. So this looks very different than anything that we've seen in the past. This is the onset of a seizure. Not all seizures look like this, but this is one seizure type of seizure pattern. This is a seizure that begins probably focally, and we can tell that because there's sort of an initial discharge here over the left temporal region, and then boom, it just spreads so quickly. We see this very high amplitude spike wave activity occurring in all channels. So this is a focal to generalized tonic-clonic seizure. Oftentimes you'll see these very high amplitude discharges coinciding with clonic activities of the face, arms, or limbs. And obviously it immediately interrupts this background activity. So this is one type of a seizure onset pattern that we might see as we're reviewing EEG. Just to give you a flavor of the different things that we see. This is a totally different type of seizure. This is what we call an absent seizure. In previous generations referred to as petit mal seizure. So this is the stopping and staring and unresponsive for about 10 seconds, which if you count out these, the time stamp is about the duration of this electrical seizure. This is a a very different type of seizure in that, yes, it involves both sides of the brain, but as you can see, it's sort of consistently this 3 hertz spike and wave pattern throughout. It doesn't get super high amplitude. We don't see a lot of muscle artifact. There's no tonic or clonic activity. There's no behavioral symptoms other than oftentimes patients will just stop whatever it is they're doing. Children will stop mid-sentence, or they'll stop mid-sport, whatever it is that they're doing, and stare or and not respond and not be aware that time has passed. In some instances, we can capture many of these over the course of the day, and neither the child nor the parent is even aware that they're having seizures. So sometimes these can be what we call subclinical. So we see them on the EEG pattern, but there's no physical seizure activity that goes hand in hand with it. That creates a bit of a challenge because obviously we think that activity is not beneficial. We don't know how harmful it is, but obviously what we're talking then about is probably starting or increasing medications, which has its own issues associated with it. So we're oftentimes trying to balance managing seizures, whether they're clinical seizures or subclinical seizures, and then medication side effects. And then, yeah, go ahead, sorry.
Okay, a couple slides before, you were talking about status epilepticus. If EEG shows innumerable nocturnal seizures,
Yeah.
would that be in that category?
So it may be characterized as electrical status epilepticus of sleep. Now that is a specific form of status epilepticus, not to be confused with patients that are coming in with convulsive status epilepticus. But it's something that definitely merits attention and aggressive management, because oftentimes what happens is we see ESES, electrical status epilepticus of sleep, in a child that has regressed. Maybe they were on track or mildly delayed in terms of their milestones, language, motor, walking, and then they regress. And if we see that ESES pattern, it really indicates we've got to jump on that, not because they're seizing, but because their neurological outcome, their cognitive outcome, their behavioral outcome is really predicated on getting better control of that.
And a continuation of that can show a cognitive decline over
Correct.
years.
Correct. Yes.
Is there excuse me, question here.
Yeah.
So for patients that have status epilepticus on a regular basis during the day, is it, I would assume that it's increased likelihood of having it at night with sleeping?
So when you say status epilepticus during the day, you mean just on the EEG? They're just electrical seizures, or they're having physically long seizures?
Yeah. So he's here right now. So he has multiple hour long, like over an hour long. So he has to go to frequent ER of absent seizures. That's
Okay, got it.
And then he has to get the rescue meds to snap him out of it. So I'm concerned about him going into status of sleep, because sometimes he wakes up exhausted, almost like his brain has run a marathon, and so I'm worried about that happening at night. So
that's a situation in which you really, I think, need to explore it a little bit more, right? So that's when either a long-term in-home ambulatory study or an elective admission to the epilepsy monitoring unit at the Children's Hospital will have to answer that question. You can see it both ways. You can see patients that have, very frequent awake seizures, but for some reason they don't tend to go into it during sleep. Their discharges tend to be more fragmented, shorter in duration, or you can see it the other way. So, but that's a question that should be answered, and we have the technology to answer it.
right. Yeah. Okay, and then I'll make one last question.
Yeah.
So when we've had explanatory EEGs before,
Yeah.
and they were saying that they couldn't tell because discharges are normal for normal brain activity, is what we were told. So we had to hit the button, and every time we saw, so if we saw a physical symptom, we had to mark an EEG with the button so
Okay.
that they can say that that was associated with the symptom. We can see the eyes flutter, we can see something.
Okay.
So if we're doing this at night, is it, I mean, what I saw looked pretty obvious that it wasn't just a discharge. But they were telling us they couldn't really rule it out that it wasn't a normal discharge if we didn't get the button. Is that a true statement? Or?
So the discharges on EEG are independent of the push buttons, right? So the push buttons are, it's great to have, but whoever's reading that EEG should be reading the EEG to some degree independent of whatever events you've identified with the push button apparatus. Does that answer the question?
I think so, because what they indicated to us is that they couldn't tell the difference between a normal brain discharge or an absent seizure discharge or whatever, unless we could associate it with symptoms by pushing a button. But we saw that there was a symptom, so we hit the button, so then they would say, oh, they saw something, and there was a discharge, so that means it was a seizure, not a normal discharge.
There's no such thing as a normal brain discharge.
Yeah, they were
So,
seeing the salve. Yes, Brady's children.
yeah, so it might have been what we call an interictal discharge, right? So it's a discharge indicating some abnormal electrical activity, and we see that all the time in patients that have even well-controlled epilepsy. So if you took any of my patients that haven't had a seizure in the last year on a med or 2 meds or 3 meds, and you hooked them up overnight, you'd probably see a dozen or 2 dozen or 100 discharges, right? But that doesn't mean they're normal. They're still abnormal, but they're not seizures, right? So what they're probably trying to get at is whether or not what they're seeing on the EEG corresponds to what you guys were seeing at home, physically.
Yeah, that answers it. Thank you very much.
But to be clear, you can have a seizure that is subclinical, so you're not going to see anything.
100% goes both ways, right? And then we see patients that have non-epileptic seizures, right? They can have behavioral spells of one kind or another that look like, and they twitch and they jerk and they blink their eyes, but there's no abnormality of the EEG. So it goes both ways. You need both the video or the eyewitness, and the EEG to put them together to answer some of those questions.
And this is
I think the last slide I had was just sort of actually the last 2 slides I had was just
sort of an indication of the kind of EEG now that we sometimes obtain from those implanted electrodes. So I showed you at the beginning, we have some patients that have 5, 7, 10, sometimes even 20 of these electrodes implanted in the brain, and each one of those electrodes might have of those wires might have 10 contacts. Each contact is a separate electrode. So all of a sudden, instead of 21 channels, you might have 50. You might have 100. You might need 2 screens to show all of the different channels from the different areas of the brain. And yet seizures oftentimes can look very similar. Sometimes they look different. Sometimes they look quite similar. So this is the beginning of a right temporal lobe seizure that, as you can probably see, starts here and here simultaneously. This one's a little bit more anterior to this one. So this is on the right side of what we call the head of the hippocampus. This is located about 2 centimeters behind in the body of the hippocampus, so that's deep in the temporal lobe. And you see in both of these electrodes this initial rhythmic activity of about 11 hertz that persists for several seconds and then starts to slow, becomes more rhythmic towards the end of the page, and then up, and then disappears. And then evolves into very sharp, spiky pattern that's a little faster. Oftentimes, the seizure has to spread to the point that it involves multiple contacts at a higher amplitude before we can pick it up on scalp, on the surface electrodes. So oftentimes,
when we have implanted electrodes, we can see the beginning of the seizure that starts a second, 5 seconds, 10 seconds, longer, maybe 30 seconds even, before we can see it on scalp, if we were to have a patient hooked up with simultaneous both scalp and what we call intracranial electrodes. So this is kind of just an illustration of how EEG has evolved in our current era of surgical evaluation for patients with drug-resistant epilepsy. So, I think I'll probably stop there. I'm right on time. And we've answered a number of questions along the way, but I'm happy to answer any other questions you have, except for that gentleman over there, who taught me everything that I knew about epilepsy. Yeah.
I have a question. So, my son has infantile spasms even though he's 18.
Okay.
So, he had them for 15 minutes.
So he still has the
Yeah,
clutch
and
spasms.
so he had them for 15 minutes without recovering. They were like 1 or 2 seconds apart for 15 minutes.
Okay.
He went in the ER. But is that 15 minutes of status epilepticus too? It's infantile spasm?
So technically, if it's continuous seizure activity for more than 5 minutes, we would call it.
So he was
status.
Okay, that's what I
epilepticus.
thought. Okay. Thank you.
Yeah.
On that last slide you showed,
Yeah.
what was happening up top with all the?
Yeah.
I was like, how's that?
So that was just baseline activity. Wasn't normal. The whole temporal lobe is somewhat pathologic. It's not normal intracranial function, but the seizures were beginning in the hippocampus. So and that's part of the challenge, is teasing out exactly where the beginning of the seizure is that evolves into the physical seizure in the forest of a lot of other abnormalities. So, yeah.
So the intracranial electrodes, are those like temporary for diagnostic? Okay, so like what are the indications for that? Like when would you suggest that for a patient? And
No,
then
that's a great
how long
question.
would they have them in there?
That's a great question. So oftentimes we don't have quite enough information based on the scalp recordings and imaging and neuropsychological testing, all of the other things that we try to put together to come up with a plan. Sometimes we come up with a hypothesis. We think seizures are coming from here, but they might also be coming from there, right? I'm not sure, or maybe from both places. Maybe there's a large area of abnormality, and we can't or don't want to take out the large area, and we think that seizures are coming from one smaller spot within that large area. Or there are multiple abnormalities on the MRI. We think that seizures are coming from one or two of them. Those are the kinds of the scenarios in which we would move forward, oftentimes with what's called a phase 2 or intracranial EEG study, where we would target those different areas of the brain, oftentimes with using robotics and sort of fancy imaging studies. You know, in our center, I can basically, on the screen, I can put a green or red or purple dot where I want this, that, or the other electrode, and then the surgeon finds the best trajectory to get the electrode into that spot. That's often done over the course of anywhere between 3 days and a week, depending on how often patients are having seizures. I mean, if they're having seizures, multiple seizures per day, we probably only need a few days of recording. But most patients end up with an intracranial study that lasts somewhere between 5 and 7 days. And then we pull out the electrodes after we have enough data to hopefully move forward with a surgical plan.
And it's just basically for focal seizures, not for generalized. It wouldn't be for the generalized.
It might be. There's certainly a trend towards looking at patients that are considered to be generalized, but not genetically generalized. Lennox-Gastaut, for example, is one example of patients that have generalized epilepsy, but we think that there are focal features to them. They may be involved, for example, the thalamus, but they're starting in the temporal lobe, or they're starting in the frontal lobe. And
So they start off as a focal and they become
they may be
generalized.
starting out as focal, or there's some preference to some focality in the brain, and we might want to prove that and then go after it either with a laser or resection or an implanted device to target for better seizure control.
Thank you.
Yeah.
Do you find that there is any different interpretations between people who look at these EEGs?
All the time.
So what would you recommend as
So
parents?
usually epilepsy centers, level 3, level 4 centers that that are staffed with people that have gone through epilepsy and EEG fellowships, and usually those are fairly consistent interpretations. It's the community neurologist who's doing their best oftentimes, because there aren't a lot of resources wherever they are, right? There's not a within 100 miles there may not be an epilepsy center, or it's just part of their routine practice that sometimes overcalls or undercalls, or there's I've seen things that are called epilepsy that clearly aren't, and I've seen things missed, so that happens. But usually within epilepsy centers, as long as the data has been reviewed by the epileptologist, that's usually a good indication that that's a trustworthy report.
Okay.
Okay. It looks like might be turnover of the room and another talk after me. So I'm gonna thank you for everybody for your attention.
Thank you.
And I'm gonna take off.